A very good afternoon to all of you, and thanks to Dr. Duru for giving me this wonderful opportunity. So my topic is optimizing IVF in PCOS women, and it's going to be an overview of IVF in PCO and may overlap with some of the topics that my previous two speakers have covered. So you'll all agree that IVF in PCOS is a challenge. It's like walking a tightrope. Mostly about balance and mostly about too less or too much. You need to balance between the two. Now, we also understand that if anovulation is the only cause of infertility for a PCOS woman, she is going to get pregnant with the first, second and third line of treatment. Most of the PCOS women will get pregnant by then. It's a very small cohort, maybe less than 5%, or some data shows 1% or 2% women will actually go on to need IVF. However, in our IVF cohort of patients, a large number, which is 20 to 30%, which is a sizable chunk, is going to be polycystic ovarian morphology, even if not syndrome, and they are going to be in the hyper-responder category, and when we deal with them, it's a big challenge. So many challenges: pre-IVF workup and optimization, which protocol for stimulation which we should choose, how to decide on the starting dose of FSH, which gonadotrophin, titrating the dose for optimal response is another big issue that we need to concern ourselves with, avoiding cycle cancellation, preventing OHSS, and of course, like last conversation that we all had right now, whether the excessive ovarian response in PCOS may lead to poor IVF outcome. That's a big question. I think Dr. Duru will cover in her lecture, but low fertilization rate, high number of immature oocytes, we are sure that is what happens, and low implantation rate also possibly, and high miscarriage rate, again questionable. But these are the many questions and issues that we need to deal with when we stimulate our patient for IVF. Now, so pre-IVF for our patient, we need to look for, investigate and treat some conditions before starting the IVF cycle, like ruling out metabolic issues. BMI and thyroid function is obvious, we all do, but it might be a good idea to look for insulin resistance, diabetes or pre-diabetes, look for hypertension, look for vitamin D deficiency, situations which are metabolic disorders and are linked with PCOS, possibly a higher prevalence in PCOS women, and treating them before starting an IVF cycle would be a good idea. Lifestyle modification, big question, but we can take this opportunity to expect the patient at least to stop smoking, reduce alcohol consumption, put them into some form of exercise, weight loss. If she has come for IVF, you're sure that she's tried weight loss all her life and has not been successful. So there's no point in us telling her lose weight and come back, but then at least putting them on to some form of dietary advice that has a reduction of dietary calories about 500, putting her into some activity, half an hour of activity that might get on to her, and she might get into that lifestyle for the rest of her life, hopefully. So we need to put and give that much effort to make this change in her life at this stage when she's come for IVF. But we know that making lifestyle changes in today's world is so difficult. I have some nice interesting pictures for you, especially when the addiction is starting at this stage. It's so damn difficult to change our addiction to inactivity and to addiction to gadgets, which is so obvious. And this is what happens when you ask them to eat just one roti or one piece of bread or something like that. And this is my favorite, which says that about 5,000 years later, archaeologists might find skeletons like this. Somebody who's glued to a smartphone, and don't miss the earphone, right. Next, pre-IVF intervention, adding metformin. So I have a question for you. All of you who practice IVF, please remember this series is only about IVF in PCOS. We of course add metformin for ovulation induction, that's a different question. But the current question is for IVF. So do you routinely prescribe metformin as co-treatment in IVF for prevention of OHSS? As a routine, never for this indication, only in obese, only if the patient is glucose intolerant or diabetic. So what I was expecting, A, is about 27% only, and only if IGT is for the majority. Well, I hope you will all agree with me later, and all the seniors here will agree that the current evidence seems to show that metformin before and during an IVF cycle is certainly beneficial. This is the recommendation of the Cochrane Review 2014, which concluded that metformin reduces incidence and severity of OHSS, increases clinical pregnancy rate, may not have an effect on live birth rate. And the recommendation was to add metformin 1000 to 2000 milligrams at least 2 months before IVF and through IVF cycle. The big question that was not really and still is not really answered is whether it is if it is as effective in obese women, BMI more than 30, or it is best for non-obese. In fact, there is evidence to show that metformin might act better for the non-obese category, may not act that well for the obese category. And the Cochrane Review of 2017 again endorsed the fact that metformin treatment before and during an ART cycle for women with PCOS definitely reduces incidence of OHSS. Now, the second pre-treatment oral contraceptive pill, the evidence out there is conflicting, and we really do not have very good evidence to say what I'm saying, but then most of us do add OCP pre-treatment when we are planning a cycle. If nothing, it reduces the LH, reduces androgen, you get a more synchronized follicular cohort, and it can be given successive and non-successive. In fact, the evidence shows that adding a successive OC pill, that means continuously for 2 months or etc., might be more beneficial than not. Then when we come to the stimulation, which stimulation protocol should we use? Now, the main aim is there should be no OHSS. There are lots of requirements, like you should get good number of follicles, and we know that there is a very narrow window of FSH which is required for it to go over the ceiling to be able to develop follicular growth. So here I have one more question for you. For all those who are practicing IVF, what is your strategy for ovulation induction in PCOS for an IVF ICSI cycle? Standard long protocol, long agonist with management if necessary, because not everybody is going to give you headaches and nightmares. If necessary, if they fall into the risk of OHSS. Mandatory antagonist protocol, mandatory agonist trigger and long protocol luteal phase rescue, mandatory freeze all, which is the one which you normally do in your practice. Okay. So I think that's quite rational, mandatory antagonist protocol, right? And then you take your call and decide whether you want to give an HCG or you want to freeze or whatever. Okay, that's fair. But this is the review of a IVF worldwide survey. I'm sure you all are aware, and you all must have answered the questions sometime or the other. They come out with all different issues related to IVF and ART. And this is an excellent survey because it involves 262 IVF units around the world, covering about 68 countries. And the results of that survey, and this was published 2015, I think, not too long back. And you'll be surprised that about 50% of the responders, IVF specialists, said that they use the antagonist protocol mandatory. However, what was surprising was that 31% still use GnRH agonist protocol in a PCOS cycle. I think, like Dr. Professor Norman and other speakers have spoken earlier, that antagonist cycle in a PCO should almost become mandatory, and the evidence also shows a 2016 large meta-analysis in which the primary outcome was live birth rate showed that antagonist is better than agonist. Another very recent 2017 systematic review which covered 50 high quality RCTs and with a primary endpoint of ongoing pregnancy. This was interesting, that's why I put it up to a little, extended the conclusions a bit more. Their conclusion was that in general IVF population, still agonist protocol gives better pregnancy rate than an antagonist. That was a bit surprising to me because I thought the whole world is changing over to antagonist because it's so much more easier to do and so much more easier on the patient. But the evidence according to this particular review said that antagonist reduces pregnancy rate in a general IVF population compared to agonist, however definitely has a lower OHSS rate. However, in a PCOS patient, PCOS and poor responder, because in both this category of patients, the primary problem is in the ovary. So GnRH antagonists do not seem to compromise ongoing pregnancy rates and are associated with less OHSS and therefore should be considered as standard treatment. So the evidence is out there, and of course the Cochrane systematic review of 2017 also recommended GnRH antagonist protocol for PCOS women for prevention of OHSS. Now the next major issue when we are dealing with an IVF patient for ovarian stimulation for IVF is how to decide on the starting dose of gonadotropin. Again, if you look at the results of that IVF worldwide, when consultants were asked what is their preference, the vast majority, 55%, responded that they usually start with 150 IU and in the PCOS woman, FSH, and then reduce it to fall somewhere between 75 and 150 to get a result. And about 18% said that they start with 225 and come down to somewhere between 150 and 100 to get an optimal result. But of course, we decide on the start. Of course, those who are lucky to have a population-based nanogram, they can use that to decide on what should be the correct dose for starting dose for IVF patient. But we of course look at these two major criteria when we decide, even for a PCO patient, what is the AMH and what is the antral follicle count to decide what should be our dose, and of course their BMI and age and all that we see to decide what should be our starting dose. For example, somebody who is really young, less than 30 or less than 25 or something like that with a low BMI, we will start with a 75 IU even when we are doing a IVF. So that is a question which is up to the clinician to decide. So here I have a question for you. Criteria for deciding patients at very high risk for OHSS, PCOS women. AFC more than 30, AMH more than 7, BMI less than 23, age less than 30, all of the above. I think this is an easy question. Okay, so all of the above is the answer, but here I want to show you one patient which is a real patient, and want to get your opinion and want to show what I am trying to say here. So this is a woman who she's 28 years, primary infertility for some 7, 8 years or 9 years. She is known polycystic ovarian syndrome, classic, which means she has anovulation, polycystic ovaries as well as hyperandrogenism, and she is obese, 34.7. She has tried ovulation induction, IUI multiple times everywhere, and she has no other apparent factor for infertility, and now she's finally with you for IVF. And she has an AMH of 15.4. Her day to antral follicle count looks something like 30, 35. We know these patients, we see them with a volume of close to 30, 25 to 30. So as expected, I put this patient on diet advice, put her on metformin 1750, slow release, and then antagonist protocol, started her with 150. She's less than 30, and although she has a high BMI, but I don't know if all of you will agree with me or not, but then I did start her with 150, which I thought was quite a bit, and that was given for 7 days. There was no response. I increased it to 225 for 7 days, again no follicular growth, increased it to 300 for another 3 to 4 days, 5 days, there was still no response, and by then I had not seen a patient like that earlier. This was some 5-7 years back, and the patient of course also lost, she also got dejected, and so the cycle was cancelled. Now in a patient like this, now that we have started doing more and more AMH, we have also started seeing the very, very high, ultra high AMH patients. And so the clinical significance of this ultra high AMH, more than 10, more than 15, is not well studied till now. And it is this group of patient which poses great challenges to us. In this very nice review, AMH and PCO, a mountain too high, the authors have written so nicely, the AMH has an inhibitory role in the ovary, increased production from each follicle rather than increased follicle number is the primary abnormality in PCO women, and PCO can be divided into ovulatory and anovulatory based on whether the granulosa cells are high or low AMH producers. PCOS with high levels of AMH are most resistant to treatment, and contrary to IVF, like we practice IVF, for us, if AMH is our yardstick, if we see good AMH, we are happy, if we see low AMH, we are unhappy, and if we see high AMH, we expect a hyper response. However, in this ultra group of patients, there could possibly be poorer response to IVF stimulation, and they probably need an extremely high dose of FSH to go over that window, or even they might fail to respond. And this was another paper that correlated phenotypes, and they divided 3 groups of AMH in the patients, 5 to 10, 10 to 15, and more than 15, and it was appreciated that the ultra high AMH groups are the severe type of PCO who are with hyperandrogenism, amenorrhea. They are the ones that are very difficult to stimulate, and possibly very high OHSs and very low clinical pregnancy rate. So that was a little bit about using AMH to decide on your starting dose, and it seems to not work with the severe PCO category. And then the other point which Dr. Sonia has so nicely elaborated is the fact that before we start stimulation, we should also look at the PCO phenotype. What is the phenotype of the patient that you have sitting in front of you who's for stimulation? And this study also nicely concluded that PCOS phenotypes, identifying them before starting an IVF cycle, seems to help clinician to identify patients at greater risk of OHSs and poorer pregnancy rates, and also decide and customize therapy and subsequently plan the trigger agent. So as you can expect, women who have higher concentrations of, who are hyperandrogenic, along with the polycystic morphology, they are the phenotypes who are likely to respond poorer, and also likely to the ones who have a polycystic ovarian morphology are obviously the ones who will have a very much higher. And then the third issue, which I'll not go into detail, is the fact that couple of these women who are not responding in spite of high doses of gonadotrophins may be the ones who have polymorphisms in various gonadotrophins receptors, and now commercially also some receptor have become available, and for these rare and small cohort of patients, we can use them to customize and take our IVF stimulation to the next level. Okay, and this was another excellent, I thought, series of 18 cases reported by Abha Majumdar's group from Delhi. They also noted what I have shown you, the case, my case that I showed you. So they have a series of 18 cases with high BMI, high waist circumference, very high AMH, very high ovarian volume with antral follicle count, and they reported that a subset of obese PCOS with very high AMH levels who otherwise appear to be severe hyper-responders may require the addition of LH. That was a side thing that they said, but they are the ones who are possibly having FSH receptor polymorphism, or because they have a very high AMH levels, or they have a abnormal LH receptor. Now, the OHSS has been covered very nicely by Dr. Madhuri, so I really don't have to say much about it, but the fact that mortality or morbidity from OHSS in an IVF clinic now is almost unacceptable. And it was the idea of OHSS free clinic that was first started by Paul. He coined the term Paul Devroy's group from Belgium, and basically that meant that the safest ovarian stimulation protocol in PCOS women was to fragment the IVF cycle into 3 steps. In the first steps, you use GnRH antagonist protocol and ovulation induction instead of the long protocol, then use a GnRH agonist trigger instead of the HCG, and freeze all and do the embryo transfer in the 3rd cycle. That is what was proposed for an IVF free, OHSS free IVF clinic. So now I have a question for you, because OHSS is somehow very underreported possibly. So the incidence may still be quite high and it's underreported. So have you ever faced serious complications of OHSS? And since this is anonymous, we can all answer truthfully. Mortality, ovarian torsion, ovarian rupture, thromboembolic phenomenon, ICU admission more than 48 hours. Answer nahi hai. It's your suggestion. Pardon me? Huh? Nahi, ABCD nahi hai. You just answer. Okay. So the good thing is that in this group who's sitting here, at least nobody's had a mortality, and 50%, I mean not 50%, because only 6 people have answered this question, have said that they've had ICU admission more than 48 hours. And torsion, quite a few, some people have faced torsion, 4 people. So yes, so this is simply unacceptable, and like Dr. Madhuri said in her covering a slide, that probably the best option currently is freeze all. But now there are papers surfacing all over the world that have reported severe OHSS even after giving a trigger, agonist trigger and freeze all approach. In fact, there is a report from India also, from Dr. Nalini Mahajan's group, that said that in spite of a segmental approach and ovarian hyperstimulation syndrome, there was a patient with, was she severe? Well, this was early onset ovarian OHSS, but the previous paper reported a severe OHSS in spite of the freeze-all protocol. So as it appears that we have not seen the last of ovulation induction for IVF in PCOS. There's a long way to go, and maybe the answer might come from something like that. It's for the researchers and the professors to tell us, but we really have to, we've not seen the end of OHSS till now. Thank you so much.